So thank you for joining us.
Thank you for having me.
Absolutely. I appreciate you being here. Can you just give us your name, background, and what your role is?
Sure. My name is Drew Livingston. My background in the last, let's say, 10 years or so has been telemedicine. My current role now is twofold. I'm Chief Innovation Officer for Harrow Health, which is a publicly traded NASDAQ company, and also CEO and co-founder of a company called Visionology, which is in the telemedicine space with a focus on ophthalmology.
And Visionology is under the Harrow umbrella, right?
Yeah.
Tell me how those things work together.
Harrow's in the business of innovation and has been for about 10 years. And so they've always been looking at how they can improve continuity of care within the realm they sit in, which is the pharmacy space. And if you look at pharmacy today, there's not a ton of innovation that goes on. I think CVS just started text messaging you recently, when your order's there. So there's not a ton. And with the software and the technology that's out there, it's a great way to add and innovate onto a business that's already sort of been established for 10 years and has a really good customer base with some of the companies that it owns.
And you guys focus mostly on ophthalmology, right?
Pretty much solely. It was started on ophthalmology and it's grown from ophthalmology, and that expands anywhere from the commercial side of the business to the patient side of the business to the formulation and drug development. So Harrow as a company is almost entirely vertically integrated in the pharmacy space, from designing our own drugs, manufacturing them, getting them out to the patients, the sales. We just don't own shipping.
Yeah. And what's unique about that? I hear you talk about that, and I know Harrow underlines that, and it is interesting and different. What makes it so
I'm not an economist, but my understanding is every dollar works harder. We get more out of every dollar spent. And so because we can do these things ourselves, we're actually able to pass on a lot of those savings back to the patient. And that's really been our model, is to cut out the PBMs, the middle folks, the middle whatever that is, because every person in there takes a little piece or adds on to the price. And then a lot of that has to be passed on to the patient. And so we said, let's just right off the bat do cash pay, affordable medications that are also accessible for patients.
And before Harrow and Visionology, you actually helped co-found telehealth provider DoxyMe. Tell me about that.
In end of 2013, early 14, I started a company called DoxyMe with another co-founder at the time. And to be honest, my father had stage 4 cancer, and he wasn't talking to the doctors, and he wouldn't listen to them if he saw them. And I tried to get him on Skype, and they said, "No, we can't do that, sir." And so I said, "There's got to be another way." And that sort of, I got looking into researching telemedicine and do you bill it or buy? And this professor had built this small little technology and really didn't know what he had. And then together, right, I'm a business guy, we partnered up, and he did the medical side, I did the business side, and we built DoxyMe. But it was really hard going for many, many years. We gave it away for free because no one was willing to pay for it. In 2014, 15, 16, and summer of 2017, I had a customer who needed some features we didn't have and said, "Hey, I'll pay for them." And that started what's the freemium model is today, where you have there's about 1 million users. It's the largest SaaS telemedicine software in the world. About 1 million patients use it a day and about 4 million doctors.
So you were sort of, way ahead of the curve, because telehealth was relevant in healthcare for, I guess, the past decade or so, but it didn't really hit the ground running until last year when the pandemic basically mandated that happen. Tell me about, what you saw during that massive change with telehealth utilization.
So before COVID, and the way Doxy really got its start was the mental health professionals, whether that was a counselor, or psychiatrist, psychologist, and we actually worked with a lot of psychologists who worked in the foster system in Texas. And we realized early on that, one person driving could only see 3 kids a day. But with telemedicine, they could see 10 to 15. And the kids were a lot more comfortable in their foster home versus being dragged to an office. And we saw all these benefits and side effects. So we put a sort of stake in the mental health ground, and they loved it, right? It was huge word of mouth, and still to this day is probably a significant amount of the users. Now it's more diverse. But as soon as COVID hit, every practice across every sort of specialty was interested in telemedicine because their doors were shut. That means revenue was turned off. That means patients didn't have access to care the way they normally did. And if you didn't have a telemedicine software or solution before COVID, you were looking for one quickly after. So we went from about 80,000 doctors at the time to 1 million.
Wow.
Within, we were getting like 30, 40,000 folks were signing up a day. So it's pretty wild.
Yeah, that is insane. And I guess as we look to the future, I see more physicians and more independent practices and, hospitals, even health systems. They want to implement telehealth. Everybody does. How do you go about, launching a telehealth program?
Honestly, it's pretty simple. People like to make it complex, but there's free solutions out there like Doxy and others where you could literally go online tonight, sign up with your information, your MPI number and what you do, and have an account in the morning. And by having an account, I mean you'll have a web link that you could actually send to your patients and start having HIPAA-compliant visits within 24 hours of setting up your account. So to me, it's very easy, but doctors and hospitals, they're not used to searching for their own technology and sources, right? They usually have this portfolio of products they pull from. So I think there's a lot of those folks are sort of tied to the old way of doing things, where you bring in a lot of vendors, you do proposals, you go through. But the truth is, it's as easy as getting a phone number for a business, right? You call up and you say, I have a new business and here's my information. And they give you a phone number. Same way telemedicine works. It's that simple. You need a couple of pieces of information. It's not complex. They're almost all HIPAA compliant. And now with the rules relaxed, you could actually use Skype and Zoom until they launch new rules next year.
Yeah, put the regulations back in
so
place.
It's even easier now than it's ever been before to provide care by telemedicine. And by the way, it's not just video and audio, right? There's synchronous, which is video and audio, and there's asynchronous, which is I send you a text or an email. And so everybody thinks it has to be audio and video, but it doesn't. It could be a phone call. It could be a text. It could be an email. And that is also considered asynchronous telemedicine, which is typically a lot easier way for patients, especially older patients, to get used to it, right? You text them first, and then you move them to video because that can be complex.
Yeah. I love that you say that it's actually pretty simple, because when I talk to, independent providers or, smaller, they're almost intimidated by it. Like, you need this large scale, technology to have it. But that's simply not the case. Anyone could really do it.
No, but that comes from the market pre-COVID and really with the state of the market when we started things in 2013. It was just, there was companies like Polycom and Cisco that had these, I call them sort of hub and spoke, where you had to have your own servers and your own networks internally so they could sell their hardware. And it was really restrictive. It was good for the traditional business model hospitals did for telemedicine before COVID, which was, hey, we have an extra room in this remote location out in the middle of nowhere, so we're going to put a camera in there and a nurse, and then we'll have the doctor at the hospital. It's called hub and spoke. It wasn't to make it as accessible as you're sitting in your home. And I think that was the big shift, accessibility.
Yeah, point of care, being able to just do it from your couch.
To be anywhere, yeah.
Yeah. Absolutely. Well, let's get into Visionology.
That'd be great.
You came to Harrow in the middle of a pandemic and helped launch Visionology. Tell me about that. I know they were building it in-house for, I guess, 3 years prior to that, but it rolled out. Tell me about it.
So the CEO and founder of Harrow Health, Mark Baum, had an idea for Visionology early on because he was working on what's now, I think, one of the most successful telemedicine dermatology brands, a company called Curology. He worked with the owner there early on. I think his name is David Lorcher, and really got a lot of the early insights to what failures, successes, and was able to see that, hey, there's something we could do in ophthalmology with this as well. And then I was just exiting my last venture, but keeping equity. My brother's there running customer service now, and we met up. And it was just like, it was a perfect match because I was ready to start innovating Doxy, which you couldn't really do with even 80,000 doctors because if you change it too much, they're not going to be happy. And you definitely can't do it with 1 million.
Yeah.
And he was ready to build a telemedicine solution on the, they're a 50-state pharmacy under this company called Imprimis RX, which is another company Harrow owns, and they can prescribe and distribute in 50 states, and that's powerful because it's really, really hard to do. And so to me, it was a unique challenge to be able to take the offline successful business and portfolio of formulations and put a digital front door on it for patients to access eye care on their terms when they need it and where they need it.
Yeah, absolutely. And you mentioned to me earlier, which I think is so funny, that you actually rode Uber or you drove for Uber for the first months as you were developing it. Why did you do that?
Because we, through Imprimis RX, we have about 10,000 customers, doctors, right? Ophthalmologists, optometrists. It's a distributed network. And in order for us to, the goal with Visionology is to connect that network, right? And part of it is connected now, but to connect it all to our system in all 50 states. So when new patients come in, we can alert the doctors. And the doctors will sign up. If you think of it like an Uber driver goes on and says, okay, I can work these hours and these days. And so we can help doctors sort of better manage this excess time, whether it be evening, morning, weekend. And they say, I got 2 hours here, 2 hours there. They put it in, and then we can match up patients in real time with the doctors who can provide care in the state to that patient. And we match so patients come into Visionology through our website. And part of what we do is we match them with a local doctor if they don't have one. And so Uber allowed me to study the sort of geofencing technology they have that puts a driver near a rider and how they alert them and motivate them. And so it was really just to see the software, see how they incentivized, not to say we do it exactly the same, but just there's some psychological cues in there. And so I was really trying to get an understanding because Uber drivers love it. Yeah. And they were telling me about it for years. So I said, I really need to try it to see how good this is.
That's so interesting. And I bet it really helps with like scheduling and, as you said, like optimizing the capacity of your physicians because you don't have, I guess, in-house physicians. You partner with them, correct?
We have some of our own as well, just because they set the protocols that we do for prescribing, and they sort of help fill in the gaps. Maybe a doctor may not be available at this time. So it's all, number one thing is continuity care for the patients. And so if their doctor or a doctor isn't available for them, we'll have one of our doctors there. But it's really the local doctors that power this and make this, because Visionology works with the local doctors. A lot of telemedicine technologies and companies try and create their own healthcare ecosystem outside, right, of let's say primary care is a great example. There's a lot of companies doing that. And when you use technology to disrupt the existing healthcare ecosystem, you really make the original one worse. And the goal with us is to take technology and layer it into the ecosystem, not to disrupt it, to make it more efficient, right? To connect people in places when they might not have been connected before, right? You could only call the doctor's office or message them. You really didn't have another way to get through outside of office hours. Yeah.
And I guess as we discussed, you guys launched at a very opportune time because telehealth was everywhere. How did you get your doctors to start utilizing your software?
Well, really the first, I would say 9 to 12 months of COVID, we were building the technology, building the platform, but also at the same time, we spoke to over 700 patients, right? We don't build things without understanding what the patient needs. So not only do we speak to the patients, I went to and met with 20 random eye doctors and told them I had different eye diseases. And because I asked for the drugs that we make to see what the patients go through and how the process and waiting. And we really built Visionology around what I learned, what other folks learned, and what we heard from the patients. And so everyone was home during the pandemic, so we had a lot of time to interview folks. It was really great. But we started to build the solution, and then we started to add on, about 5 states to test with our doctors in there to really understand how patients were going to act, what type of ads we could use to engage users, what were the conversations on social media. So part of building Visionology during the year of COVID was me visiting with doctors right before the offices were shut down, speaking with patients at home, and really taking the time to build in the things that we heard from patients and that I experienced going through meeting with doctors and having different eye diseases at these doctors' offices to see the process. Where could I make it more efficient? Was it the prescribing process? Was it, scheduling, and just what are those pain points that doctors have?
Yeah, that's interesting. And you also talked about the consumer experience through all that. What did you want to solve after what you saw was going on when you went to those and said you had these different diseases or wanted certain medicines?
Well, it's interesting. I just saw a lot of different ways for me to treat. I went in for dry disease was most of it. And so I got a lot of different solutions and all positive, right, to treat it. And so it was very disparate, right, where I wished I had, a more focused way to do it. But the doctors do it well. But what I also realized is a disease like dry eye. A lot of the doctors told me that, I could diagnose this and you don't have to be here, right? I could ask you these questions. And that really piqued my interest. And we got into they have these doctors who put together these groups of medical questions that are really the same questions doctors ask you in an office. And we turn that into an online exam that patients can go through. And then we package up that information, send it to the doctor in real time. They review it. And they either say, oh, well, we got questions, and then they'll text and communicate or a video visit with the patient, or they'll prescribe, and the patient, everything will go out to them. So
so it's just a more direct way to get what you need.
Correct. And when they said that dry eye patients specifically, right, I would sort of say, I talk about telemedicine. Hey, do you think we could do this, at home? And they all were open to it, right? And they were actually saying, we got to keep the seats open in the office. We're really busy for patients who might need surgery or cataracts or glaucoma. And that really struck a chord with me because those are blinding conditions. Dry eye is a chronic eye disease, right? But you're not going to go blind from it.
Yeah.
And so it's like, how do you balance the number of doctors that are out there and the needs of all the patients? And I look at glaucoma as a specific space because there's about 600 glaucoma specialists in the U.S. and dwindling. There's about 3 million glaucoma patients. And so there's no way they could see all those patients, right, that need to be seen. And so through Visionology, we have a test called Sparks. And this is also, so it's not just at-home prescriptions, it's at-home DX or at-home diagnostics. And so we did an exclusive deal with this guy, George Spaeth, and he is like the guy in glaucoma. Like he's a key opinion leader. He's been it for years, retired now, but he invented this so people could track the progression of their glaucoma and other eye diseases at home. And it's published clinical papers. It's proven that it works. Huge.
Yeah.
And so we started talking to glaucoma doctors and said, hey, what if we could assist and get this data, help these patients monitor their eye disease at home, and then when things get out of whack, we'll let you know and we'll help them schedule an appointment. They said, that would be great.
Yeah.
Because I can't see all the patients. I have to keep the chair open for patients who actually need a surgery or maybe they're going blind in one eye. Not that the other patients are any less important, but through technology, we can have a tool to update them in real time and really hug that customer and continue that care once they step outside the office and be there as a sort of an assist for the doctors.
To me, it sounds like a meeting that could have been an email. Like, you have a really sort of acute eye problem that you don't really need to go into the doctor. You just,
it's a great way to look at it.
It's like a pretty easy thing. The doctor's going to know what's wrong and they can just give you the help without, as you said, filling up those spaces for people that might need surgery or have more extreme conditions. But I also think that the Sparks thing's interesting because you have tools in your telehealth program that go beyond just communicating. You can actually monitor these diseases, right? Tell me about those different things that you added into the software.
Well, we started with Sparks, but the software is added so we could add in things like color vision tests, right?
Yeah.
For example, color vision, right? Red, yellow, green is the most common color vision disease. Now, wouldn't you want to know if your Uber driver passed like a color vision test? They can see the lights. So you could do that with telemedicine, right? In Visionology, where you could send it and distribute it to all their drivers, right? So they could take this test. So we're starting with glaucoma because that's a blinding disease. And not only does the Sparks software track the progression of an eye disease, glaucoma, cataracts, macular degeneration, it also can be used as a screener. And so let's say I go to like a Kaiser, right, who self-insures, and, their whole thing is how can I de-risk my older population? And there's not a real simple way to de-risk glaucoma. And do you have it, do you not? And so with our software, imagine they have 10 million, I don't know what the number is, 10 million 60-plus-year-old patients, glaucoma aged, and they could screen them at once, simply. So the power of that is really grows, and that's where the value of technology is, right? You get the power of the physical in-office experience coupled with the power of software, telemedicine software, and diagnostics that can reach people in their home and be used without the need of a doctor.
Yeah, absolutely. And you've called it, the front door to care. But I guess I also see it as a front door to the other things that Harrow offers, right? How do you use telehealth strategically within Harrow, and how does it, cooperate with your other subsidiaries?
So let me talk about Imprimis RX first, because that's probably the biggest subsidiary and it is the biggest subsidiary today, but it is also has the best synergies for us. And so they make the drugs, right? We have this huge pharmacy up in New Jersey, shipped to all 50 states. They built this with one product 10 years ago, and they built it on word of mouth from the doctors and the patients. But for 10 years, it was only being sold direct to doctors, then to patients, right? Never could patients access things from their home. And so over the 10 years, they've built up a huge database of patients that have chronic eye diseases. I'll make it up. Let's say there's 1 million. And so there's 1 million, and maybe they aren't our customers today, but we know they have chronic eye care disease. Well, we can now go to those patients with Sparks test, with a simple text or email, and allow them to track, do you want to monitor your glaucoma from home or cataracts, and work with them. And most insurances cover it as well. And so that's the other thing. We're going to get into a billable service with Medicare, Medicaid, and other providers with Sparks, because it can be covered. And by the way, a lot of patients are going to get it for free in the beginning too. And we're going to have programs that if your insurance doesn't cover it and you make under a certain amount, it'll always be free, because it's not, the money will come, but it's number one is patients, right?
Right.
Can we help the patient? And this is why we always had a free thing at Doxy, and it sort of flows into this. It's really like a human right to have access to care. And we always believe the technology, right, shouldn't be, the technology shouldn't cost somebody if you want to see a doctor HIPAA compliantly. That really flows into diagnostics to an extent too with eye care, right? Because a lot of people can't afford it. Maybe they don't have insurance. Why should they not be able to take this test and track their glaucoma or screen for it? So it's going to sit on all sides of the fence. But to circle back to how it ties into Imprimis, there's also a lot of glaucoma doctors at Imprimis. And so we're going to work with them with this Sparks program and offer this additional data to them if they want it, to help monitor their patients outside. And so, the way we look at it is, how can we not we don't want to compete with the doctors. We never will. It's not our model. But how can we help the doctors take technology, which we know really well, right, in the telemedicine space, and help them layer that into their practices, their patient pool, in a simple way that's not going to change the way they do things, and then give them that data on those patients when they need it.
And how did the doctors like the technology, and how have you formatted it for them?
So the doctors so far like the technology. They like the idea of what we're doing with Visionology. They like how patients are onboarded. Sparks, we're in the process of it exists today. There's a Sparks website, but it needs some improvements for the patient experience, because it was developed 7 or 8 years ago, but it works. And so we're in the middle of doing that, but we're actually working with glaucoma doctors and glaucoma patients to speak with them and say, hey, how does this design work? What needs do you have? When do you want to be notified? Do you want to be notified on the weekends or at any time? And so really understand how we layer in what insights they need and when they need them and how they want to receive them.
And I think you told me that you also do sort of like what Uber does. When they use it more, they get more referrals. Is that right? How does that work?
So as we go into market, let's say we're in Nashville, Tennessee. Let's say I have 100 doctors in Nashville, Tennessee, right, in this area. And there's probably not 100, there's 50. And so over time, the way Uber works is that if a driver, right, is more responsive and is more engaged, right, is the way you look at it, they give them, more rides in essence. And so not to put a patient into the Uber pool, but the way it would work is that if we have a doctor who's willing to work more hours, right, if they're saying, oh, I'm going to work all weekend, well, then they're naturally going to get more patients, right? Because they're on more hours. And so the more engaged a doctor is, right, the more, and it's not about a speed of a prescription, right? Because things need to be looked at and considered, but it's really about how much time do they have to, work with patients sort of outside of their normal hours. And so we'll be able to, hey, the folks who work more, we're going to send them more. But Visionology also generates referrals for LASIK, for cataract surgery, for glaucoma patients, because we get a lot of patients that come in who don't have a local doctor. And so we're able to send those referrals through to our network of doctors who work with us.
Yeah, I guess that's especially beneficial in like rural areas where they don't have these specialties.
It's huge.
Yeah.
And rural is one of the biggest places that needs this. It's needed everywhere because, especially with COVID, and it's going to be this or something else, patients, and we deal with an older patient population because that's who has glaucoma and cataracts and dry disease more and more these days. We need to have, we need to open up the access using telemedicine, and it'll sort of even out, it'll more evenly distribute the available time the doctors have using technology to meet those needs.
Yeah, absolutely. And I know the access is key. It's so huge, but I know the other side of that I hear from, physicians and everyone is that we need to make sure that it has the same efficacy as in-person visits, that we don't jeopardize our standards of care. How do you measure that?
It really, it's working with the local patient and the doctor. And so in no way, shape, or form do we want to replace the doctor. The office visit, that annual eye exam is of huge importance, and especially as you get older. And so really we listen to the patients and listen to the doctor. If the patient says something's not right, and it's not something that we even feel comfortable, and we have protocols, right? We're not going to diagnose if you say, oh, I feel like I'm having a pressure spike because of my glaucoma. Well, you need to go see the doctor, and we're going to help you get an appointment. So our team actually helps schedule that. We'll call up the doctor's office and say, hey, we have Mrs. Johnson. She needs to get in. She's had a pressure spike. And so we'll actually sort of this little white glove service of assisting. And our older patients like that, right? Because we can do things that he can't. They don't want to wait on hold or call the doctor. And so if they want to do it, it's fine. But it's a fine line to walk, and we're always learning as we go. But we never do anything that where we're trying to say, oh, we want to replace the eye doctor, because they have tools and process, and there's things they need to see in person. And so we want them. We want that patient to go in. And that's why we're there, right? To identify if they have that need and to help steer them. Because if they find it on their own, they may or may not choose to go into the doctor. And so at least we can help recommend that, hey, we think you need to go doctor, and let the doctor know too.
Yeah, that's interesting because it almost gets into the care coordination realm. Like you're partnering with the doctor, but also making sure that that continuance of care is there for the patient, which I guess leads to our next question is that front to end, what does it look like for a consumer to use Visionology and, the connecting services? Like, I need to go see a doctor. I have this thing with my eyes, and I use it. How do I access it? And then what happens after I access it?
So a patient would go to visionology.com. They would, right now it's just for dry eye, but we have next month or two, we have EpiBrim, which is our red eye allergy drop, which works in under 2 minutes. I test it all the time because I have bad allergies, and it works really well. We have a lid lifter drop we're working on that for women that will actually, if you have droopy eyes, it's if you don't want to have a cosmetic surgery, it's like Botox for the eyes almost.
Yeah, that's so funny.
Things like that. So the patient will come to the site, they'll read about dry, and they'll take a doctor-approved exam, and we'll get all their basic. Think about it. You walk into your doctor's office, and the nurse comes in and meets with you and asks you what's going on today, right?
Yeah.
And they probably know your name already, and they say, okay, what are you experiencing, right? Is it painful? Are you getting redness? What are the symptoms? And they identify that it might be dry eye, and then they have the doctor come in. We do the same thing. We take the same questions that nurse or doctor is going to ask in the office, put them into a quiz. They take the exam, and they say, do you have cataracts? Do you wear contacts? What drugs are you not allowed to take? Do you have any allergies? All the stuff they'd ask you in the office. And we wrap it up nice and neat, and they pay, and then they hit submit. And then, that's it. And they are sent a message saying, hey, the doctor is going to review this. They're going to reach out if they have any questions at all. If not, you'll receive a notification when your prescription is processed. And they either speak with the doctor or they get that notification. And then we notify them when it ships. And then we follow up with them. It's very hands-on. So that first week when they get the drops, does CVS ever call you when you get your meds?
Not when I get them, no.
And Walgreens doesn't, and a lot of people don't. But it's really important that first week that you what we call hug the customer, because it might be a new therapy. They might have questions, and so we're there for them, right? And they can also call their doctor too. But a lot of we offer that. We offer that sort of hands-on that first week and even longer, and then call 7 days a week. And if they need support, it's really easy. We have a 1-800 number they can call or text. We have a chat button on the window that 24 hours a day they can text. And we have a 24/7 line to the pharmacy. And so they can always get a pharmacist at any hour if something happens and, our support staff is not on.
Yeah, wow. That's like totally different experience from, when I just go to my doctor. How long is the turnaround from when you do that initial screening to when the doctor, reaches out to you or prescribes you something? Or
now the doctors, keep in mind that they also have practices, right? And so they're not sitting at home waiting all day for this, and so it's in between patients or lunch or at the end of the day. Typically we select. So typically within 24 hours or less, usually less, the doctor will review the exam and either contact you to follow up or approve your prescription. And then a day, if it's approved during the day, it'll go out that same day, and then typically it arrives in just a couple days. And we put them in nice little plastic bags with the instructions printed on there because our patients are older. So they have a bag that they can carry with them, and it tells them how many drops to put in and when in the night or in the morning or the afternoon. And we try and do things a little differently, but not change it so much that you say, oh, this isn't a pharmacy. It's a pharmacy with, we love you. We love the customer a little more. So
that's cool. So I guess it eliminates the need to schedule an appointment. You do the screening on your time as a patient, and then the doctor picks it up and returns the diagnosis or the prescription, what they need.
Yeah, and that's the interesting part too. When we first started this, and I track all the trends. The weekends, Saturday mornings, it was unbelievable. We had so many people coming on, and support was so busy. And then Sunday nights, and then evenings, it was like right around 6:30, right after dinner. It was wild. And
when all the offices closed.
Exactly. So we were actually filling a need that we could see from the patients just based on the time that they were accessing us, because this is outside of normal business hours. So.
Yeah, that's so neat. Because I hear, I'm interviewing like IVX Health, and they do infusion centers, and they try to take a consumer approach too. And their whole thing is like, we're open nights and weekends because that's when people have time for this care.
Yeah. But if you look at what we're doing, we trademarked this term, it's called, or copyright, it's called eye care as a service. And that's what we're doing, right? There's software as a service, we're eye care as a service. So it's access to care on your terms when you need it, whether it's at home, at the office, and it includes, diagnostics, it includes us helping you get an appointment with your doctor. And in the future, it might even include, a mobile version. Maybe we go to a retirement home and we have a special exam machine in there to look at cataracts up close, or something else, right? Or macular degeneration. And so, over time, I think care is really going to be a combination of primaries in office. Secondary is telemedicine for the needs when that office is closed, or you have that you need something and you want to talk to a care provider. And then for a certain subset of the population, older, you're going to have to go to them sometimes because they're not able to get to the office. And that's really for the rural areas where access to care is really a big issue.
Yeah. And I guess switching gears a little bit, how does this all, get paid for? Because I know you said that you provide the technology to the physicians, and I as a consumer can just go to Visionology, do the screening, pay for it, and then get all those services. I guess I'm wondering how it correlates with insurance payers, self-paying. How does that all come together?
So Visionology and the pharmacy we have now is pretty much all cash pay. Now, Harrow is investing in FDA approved drugs, right, or drugs that have a path to FDA approval. So we are getting into the billing side of things, but we really made our mark on a cash pay, affordability by cutting out all the middlemen. So we don't want to change from that. That'll always be there in some shape or form. And so with Doxy.me, or I'm sorry, with Visionology, it's really about right now offering the cash pay solutions. As we grow with Sparks, we have a path to not only getting FDA cleared or approved status on one side, but also there are codes that exist today that we can get paid on, and doctors can get paid on if they want to administer it, right? We'll give them the software. And so putting out the telemedicine technology today is not an expensive undertaking because a lot of it's pre-built. I mean, you can go to a company like Twilio and you could have one in 24 hours. Yeah. Now, when I started doing it, it took a year to build, right? but things have changed for the better rapidly, and so you could really be up and running pretty quickly. So the underlying cost to operate the telemedicine side is not. And if you look at the labor side, right, we're using doctors, and we hire some full-time, but the majority of them have day jobs. And this is, and we can compensate them, by the way, for the work they do as well, legally, which is a big thing too. And so we're able to, position the costs in a way that we are profitable, and that as we grow, we're going to be profitable because we want to put that money back into providing more access for care for patients. We have a lot of affordability programs we want to do, and so it's really about building back into the patients that helped us get where we are today, and the doctors as well.
Yeah, absolutely. It sounds like there's fairly low operating costs that it maintains that affordability.
Yes, and we get the economies of scale from being vertically integrated with Imprimis, and so if I had to go do this from scratch, I may have said, okay, let me think about this. But the fact that I could come in and it was really this digital front door, right, for eye care as a service onto a pharmacy that has proven formulations, super happy patients, and super happy doctors. Once I saw that, I said, oh, this is, growing in a business organically is extremely hard to do, especially in the pharmacy space. And so there's a lot of connectivity to patients and doctors who support us, and that's why we went to them and made sure we had their blessing before we even stepped into the space.
Yeah, for sure. Well, my last question, and it comes from our previous conversation that you told me that your mom was telling you to stop investing in telehealth. Yes. Don't do it. You've been pushing telehealth for a long time, long before people thought it would come to what it is today. What have you been most surprised or excited about with this mass rollout? Well, what do you see for the future?
I'll say I'm excited. I didn't listen to my mother's advice and shut down the business in 2018 because that would have been a different story. But I think what I've been most encouraged about is the doctors who early on have tried telemedicine, and once they saw the value that their patients got, they were in it for life. And that, to me, kept me going and keeps me going now, is that I know that if the patient tries it or the doctor tries it, it's going to really change the way they think about providing care in a positive way. And doctors, they had so much more time, right? They could leave the office a little early, work from home, maybe work on the weekends or a day or two from home in the office. And it just gave them a lot more flexibility, which led to more happiness, where they weren't tied to a physical location so much. And patients just were amazed that they could even do this like legally, right, and compliantly.
Yeah.
And they were just so... people in rural areas and even in cities and stuff, it's so hard to get access to care, or maybe you're having a bad day, you have to go see the therapist and you don't feel like going out in public. Well, you could be in the comfort of your home, and there's something really like, it makes the patient happy if they can stay at home and maybe a little more open. So I was surprised how open people were, and also how many older folks, right, demographics were willing to try this and went through, right, they're willing to restart their router if they had to, or do these little things in the beginning. Right now it's simpler, but I was always encouraged by the passion of the doctors and the patients who use this.
Yeah. Cool. Well, thank you so much for coming on.
Thank you for having me. I really appreciate it.